Lagos among MSMs. And then if we look at this 2016 publication, we can see that there are lots of changes because we have a lot of social changes in our environment, and we need to be aware of that. In this 2016 presentation, that was the earliest that the latest that I saw, the prevalence of chlamydia was 17% in Abuja and 18.3% in Lagos. So you can see the wide difference and the jump. And then prevalence of gonorrhea in Abuja was 19.1% and 25.8%. Now we need to know that this study was carried out using this Aptima Combo 2 assay, which is a target amplification nucleic acid probe test for the in vitro qualitative detection and differentiation of ribosomal RNA in chlamydia and gonorrhea. And probably that's why they were able to yield a higher prevalence in this subset of population. I don't know what your own findings have been. I don't know if you're seeing cases of gonorrhea, but from this study, it's apparent that we probably have these cases, but we're not testing properly. Now, in the US here, the Center for Disease Control reported that they had over 2.5 million cases of chlamydia, gonorrhea, and syphilis in 2019, and an almost 30% increase in these reportable STDs occurred between 2015 and 2019. The sharpest increase was in cases of congenital syphilis, and the burden was notably higher in racial and ethnic minority groups, gay and bisexual men, and youths that were aged between 15 and 24 years. Of course, we know there are no more borders. We have globalization. So if we are having this increase this year, we just be sure that we're having it all over the world. And the report by the Treatment Action Group highlighted gaps in the development of new tools for STI prevention, example, vaccines, diagnostics and testing. And these gaps are deterrents, proper treatment. They called for major new investments in STI research. Other challenges that need to be addressed in STI management are available structured, coordinated, sustained and integrated STI programs, and the increasing threat of antimicrobial resistance. And these programs, especially in Nigeria, where we have a lot of subspecialties struggling for STI programs, we have a lot of fragmentation of these services, and integration is key if we have to manage its STIs appropriately. And just put this up for us to see, this is a puzzle. We know about syndemics. Just to remind us about syndemics, there are sets of linked health problems that interact synergistically and contribute to excess burden of disease in a population. It may be used to describe co-occurring and interrelated epidemics of HIV, viral hepatitis, substance use diseases, and STIs, and they are associated with social determinants of health. I also found this thing on chemsex and gonorrhea, and we know that we're having a lot of illicit drug use, even in Nigeria right now as we speak. So we need to be aware of this. And chemsex is a term that is used to describe a combination of sex and illicit drugs, in particular stimulants among groups of MSMs to intensify and extend their sexual sessions. And then these are the common chemsex drugs. Now, we used to think that crystal meth was an exotic drug. I remember one time in Abakaliki, I saw a young boy who was, I think, about 17 years, and I found out he had been on crystal meth. And he said, oh, he buys them on the streets of Lagos. Usually those that are into Yahoo business, Yahoo Plus, G Plus, and all that, they're able to afford these exotic drugs, and they use them quite commonly. So we need to be aware of it. We also know that chemsex may also be combined with oral erectile dysfunction medications. And all these are associated with higher risk of gonorrhea in MSM. Why am I talking about MSM? We have MSM, but we also have a lot of them who are bisexual. So we need to be aware of this. Now, what's the rationale for making a case for improvement in laboratory diagnosis of STIs? We know that some STIs are curable with appropriate therapy. while some are not, but may improve following use of suppressive therapy, and lab testing plays a major role in the diagnosis and treatment. And so many testing methods. I just this up just to show us a few of them, and then we'll just discuss a few of them. I'm not going to talk about HCV, I'm not going to talk about HIV, because those ones are also handled in other areas. But we'll just talk about a few of them, and then we'll begin to summarize. So nucleic acid amplification test. I found out this is one of the new advances. It's like in almost all of them, most of them are using NAT in their diagnosis. And these nucleic amplification tests, nucleic acid amplification tests are used to detect a specific nucleic acid sequence. And this enables identification of a pathogenic species or organisms, of an organism in a sample. The good thing about this is that genetic materials, rather than antigens or antibodies, are detected. So you can make an early diagnosis. And that's why these are increasingly being used in making diagnoses of not just STDs, but in a lot of other things, including the recent pandemic of coronavirus. They usually employ amplification of the genetic material through polymerase chain reaction, strand displacement assay, or transcription-mediated assays. And the sequence of the nucleic acids, first of all, is identified, then probes will be attached to them. Probes that will attach to them are developed by the scientists. And then by amplification, series of repeated chemical reactions make numerous copies of the DNA or RNA of interest, making them easier to identify. So first of all, you identify these nucleic acids, and then you amplify them. And then when amplification has occurred, the more conventional tests are usually are now employed, and usually involve some form of nucleic acid hybridization to detect the organism. And the sample is probed with an artificially produced complementary strand of DNA or RNA that has been labeled in some way to make it easy to detect. And I just put this just to I really can't. Okay, I just put this to illustrate how this amplification is done for chlamydia. So you have these primers, and then you have your DNA polymerase. Then you have the DNA strands that have been identified, and they are separated by heating. Then you have the unattached. When you separate them, you have these unattached primers, and they are fixed here, and then they are annealed, and then you make your new DNA molecules and couple them, and then the process is repeated, and that's how you amplify them. And then after that, this kind of like where you have, so this where you have your blood sample, whether it's or urine sample, or whatever sample you're going to use, then and you put it in this chamber, and then after the amplification, then the tests are carried out. So for chlamydia and gonorrhea, we know that transmission is there, vaginal, oral, or anal intercourse. And then you have screening recommendations. I don't know if we're not screening routinely, but here in the US, they recommend that females undergo annual screening once they are less than 25 years, and then screening during the initial prenatal visit. Then for males, screening is recommended for young males in areas with high prevalence, and for men who have sex with men. But you include extragenital screening for MSMs to rule out pharyngeal and or rectal infections. The specimen of choice for this screening for urogenital infections for females usually first catch urine, endocervical swabs, and provider collected or self-collected vaginal swabs in a clinical setting, while for males is first catch urine and urethral swab. Now for the testing, nucleic amplification test, I've talked about some of the advantages. They have superior diagnostic and analytical sensitivity for the detection of infection. And most of the assays have approval for vaginal, urethral, cervical, and urine specimens. Culture is still required in certain situations, so let's not throw it out through the window. Usually require cultures in cases of sexual assault in boys and extragenital exposure in girls. And then some labs must maintain the ability to culture to monitor trends in epidemiology and antibiotic sensitivity patterns. Then you also have antigen testing for these conditions. So I just talked about specifics for Neisseria gonorrhea. Specimens for both gram stain and culture must be obtained directly from the urethra or cervix. Now, in this case, we're talking about for diagnosis. We talked about screening. This is for diagnosis. So you obtain specimens from the urethra or cervix with a special swab. Non-culture techniques detect gonococcal antigens, gonococcal enzyme activity, or gonococcal genetic material. And gram stain has good sensitivity and specificity, but that's in symptomatic men that have urethral discharge. Doesn't really have specificity or sensitivity in females because most of them are asymptomatic. Single-stranded DNA probe to detect gonococcal ribosomal RNAs have been developed and are approved for urethral and endocervical swabs. DNA probes are fairly sensitive and highly specific for gonorrhea, and it's comparable to cultures in some studies. Now, the nucleic acid amplification tests are the most used diagnostic tests right now. They amplify the Neisseria gonorrhea DNA or RNA using the PCR or TMA or any of those other things we talked about. And they are more sensitive, can provide results more rapidly within hours compared with culture, but they are definitely more expensive. For women, the CDC recommends that the tests are run on vaginal swabs, but you can use urine, endocervical, and liquid pap medium as alternative specimens. And for men, the recommendation is on first catch urine, even though urethral swabs are also acceptable. So of course, that makes it easy to collect specimens. Then treatment of gonorrhea, where I looked at current literature, and it's still a combination of IM ceftriaxone with either oral azithromycin or doxycycline. And then you can use cefixime in combination with either azithromycin or doxycycline as an alternative regimen. But when you have cephalosporin allergy, it's recommended that you use high dose azithromycin. A test of cure is recommended 1 to 2 weeks after therapy to ensure eradication of the infection when alternative regimens are used. For chlamydia, the specifics for diagnosis, usually we know that there's limitation in culture. For culture, even though it's the gold standard, it has its limitation. And I think the next slide, the next few slides talks about some of the limitations. So non-culture techniques such as direct fluorescent antibody test, enzyme immunoassay, and direct DNA probes have been developed. And rapid point of care tests have also been developed, which provide a quick and easy test result. But you have new point of care nucleic acid antigen test. Example, expert assay of Cepheid, CTNG, and those that use technology, isothermal amplification. They have all been developed. So they are developing point of care antigen tests, not just the genetic test, the antigen test, but nucleic acid amplification test as well. Then the regular nucleic acid amplification test techniques utilize PCR or TMA, and they have superior sensitivity and specificity. And this can be increased using coated magnetic beads nucleic acids. They have the capacity to detect both DK and L1 to L3 serotypes of Chlamydia trachomatis, but will not distinguish between the two serotypes. You would need additional testing to reliably distinguish between DK and LGB serotypes. And what's the treatment? Macrolides, tetracyclines, and quinolones, except for ciprofloxacin, are all effective against chlamydia. There's no convincing emerging resistance as seen in gonorrhea. So for uncomplicated lower genital tract infection, 1 gram azithromycin or 1 week course of doxycycline may be used. In single dose therapy, individuals should abstain for 7 days following the treatment. And all women treated for chlamydia should be rescreened 3 to 4 months after therapy. In pregnant women, azithromycin or erythromycin is recommended. What are the cultural challenges for chlamydia? We know that cell culture is required to cultivate the organism. Invasive specimen collection is required in order to collect adequate epithelial cells, and samples must be immediately processed and inoculated onto a cell monolayer. And to detect the organism, infected cells are incubated with chlamydial antibodies. It's not practical for some clinical laboratories. and usually reserved, especially in the US here, for public health facilities. Neisseria gonorrhea, the culture may be difficult due to the fastidious nature of the organism. Then you have possible inhibitory effects of wood or cotton on the growth of Neisseria gonorrhea. So there's a need to collect the specimen with swabs on that are on metal or plastic shafts. Then you require specialized transport medium. You require selective and enriched growth media and incubation in an increased carbon dioxide environment before you can isolate the organism. These are some of the cultural challenges. Now we'll go on to talk about Mycoplasma genitalium, which is one of the common sexually transmitted diseases that also cause male urethritis and are approximately responsible for 15 to 20% of non-gonococcal urethritis in the US, according to this study here, and then 20 to 25% of non-chlamydial NGUs. And then the pathogenic role is less definitive in women than it is in men. And like chlamydia and gonococcal infections, it may be asymptomatic. Diagnosis is also, the NAT is also the preferred method because culture may take up to 6 months since the organism is really slow growing. And in the absence of validated tests, you consider Mycoplasma genitalium when you have cases of persistent or recurrent urethritis and persistent or recurrent cases of cervicitis and PID. So it's something we need to be aware of. Treatment is with antibiotics which target cell wall biosynthesis. Antibiotics that target cell wall biosynthesis are ineffective because the organism lacks a cell wall. So treatment usually occurs in the context of syndromic management for urethritis. So what you use for gonorrhea and syphilis, you use, but when you find out a person is not responding, in treatment-resistant cases, moxifloxacin is used. But we know that moxifloxacin is expensive. So for syphilis, screening is usually not recommended except in high-risk cases due to the low predictive value. Routine screening is recommended for all pregnant women. We know about that. There's a paradigm shift. Initially, non-treponemal testing was used for initial screening in most settings, and then positive results are confirmed by treponemal specific testing. But with the paradigm shift, you now have reverse screening algorithm in some centers due to the recent development of automated treponemal serologic immunoassays. So usually what you now do is the treponemal serologic immunoassays and then go ahead to do the non-treponemal testing. So that's the reverse screening algorithm, and just wanted to put it out there. And these are the treponemal tests. I don't think we'll go into that. They just put this just to remind us about the dark field microscopy, which is still quite relevant in primary syphilis and helps. It shows this corkscrew pattern of the organism and is most sensitive when performed by an experienced observer on an adequate sample of fluid obtained from the surface of a chancre. Now that's a tall order because many of our patients do not come at this stage of primary syphilis. So probably that's why we're not really getting a lot of positive cases. Now, secondary syphilis can also be diagnosed by dark field microscopy lesional specimen, and then serologic tests are more sensitive than in primary syphilis. Treatment is still, I found out, is still parenteral penicillin G, is still the preferred treatment for all stages of syphilis. And duration of treatment depends on the stage of syphilis. Now, this is I think I just put this up just to show the different sensitivity patterns of the FTA, ABS, and then the immunoassays. And so this is just an article to show the paradigm shift about the reverse testing for syphilis. You can look at it later when you look at the slides. Then CSF treponemal antibody test is, well, I think it's been there for a while. It's a breakthrough in the diagnosis of neurosyphilis. So just for us to know that we can do a CSF treponemal antibody test for neurosyphilis. Herpes simplex. We have more than 500 million people living with viral herpes simplex type 2 infection. But I think I just wanted to bring out that the epidemiology of HSV is changing, and genital herpes, as we already know, is increasingly being caused by HSV1 in industrialized countries. What are the lab methods? Lab methods, you can still do your viral culture, antigen detection, and DNA detection based on nucleic acid and testing by PCR assay. Tube culture isolation, was the traditional gold standard for HSV and is still commonly used, especially in resource-poor settings. And then viral antigen can be detected by direct immunofluorescence assay or enzyme immunoassay. Serological assays are available for type-specific testing of HSV1 and 2. Positive, it's important to know that a positive IgG is not diagnostic of an active infection, and detection of IgM testing is neither type-specific nor indicative of recent infection. Then nucleic acid amplification test is done by PCR. It doesn't rule out latent infection in a negative test or in a patient with no active lesions. And currently there are molecular assays for detection of HSV DNA in genital and oral lesions that provide rapid test results with detection rates superior to viral culture. Treatment is still with acyclovir, the ones that we know, even though we're beginning to see cases of resistance to acyclovir. Valacyclovir, famciclovir, foscarnet in acyclovir and valacyclovir resistance can be used. Then there are newer drugs, amenamivir and pritelivir, newer drugs, research drugs that have been tried in some settings and have been found to reduce viral shedding and improve the symptoms, especially in primary herpes simplex. Then the use of microbicides. Tenofovir gel has also been tried, and not the tablets, but just the topical agents. And then this Viva gel, which contains SPL, that the active ingredient SPL 7013, are also agents that have been tried to reduce the acquisition of herpes simplex virus, genital herpes simplex virus. And I saw this article, I just put it up, the essential oils for the treatment of herpes virus infection. This is an article that was published in Chemotherapy in 2019. So, I mean, we can just think about that. Human papilloma virus. We know that it's important that we screen. I just put this out there just for us to remember that screening is important. Even though annual screening is no longer recommended, the women need to be screened at least every 3 years. I don't know, those of us that are females, I don't know how often we do. I know I'm culprit. I don't know how many times I have done the screening, but it's important that we do that. And specimens for HPV testing include the same swab that was used for cytology testing, and then, or you could also do a separate swab or the residual fluid from liquid-based cytology testing. Currently available nucleic acid amplification test for detection of human papilloma virus include this test that you can see out here. Then we also need to remember Trichomonas vaginalis, and screening is still with wet mount microscopy, is low cost, convenient, commonly used for detection of trichomonas, but it has a poor sensitivity, which is usually 60 to 70%. Then rapid antigen tests are also available, but they also have low sensitivity. But the good thing is that they are available at the point of care for tests on vaginal secretions. Then molecular testing by nucleic acid antigen amplification tests are gold standard right now. And then the sensitivity and specificity is between 95 to 100%. Tests available to assay vaginal, and you can test this. You can use this test on vaginal, cervical, or urine specimens from women, and then urine specimens from men. Then just a word about advancements in the field of intravaginal small interfering RNAs. So these are vaginally administered agents containing small interfering RNAs targeting either viral genes or host factors, and they are potential candidates for controlling sexually transmitted diseases. Now, intravaginal application of these agents may be used in the prevention of human immunodeficiency virus and prevention of human papillomavirus infection. What are the goals of STI treatment optimization? So you have these 4 quadrants. You have global and national surveillance. To optimize your treatments for sexually transmitted infections and all that, you need to optimize, you really need to look at all these target areas, global and national surveillance. And then detection and diagnostic methods, just like we talked, we need to develop sensitive rapid point of care tests for detection of STIs and develop this rapid test for antimicrobial resistance prediction in order to guide individualized therapies, implement mycoplasma genitalium macrolide resistance testing before treatment, identify novel antimicrobial resistance determinants, and promote newer technologies. And then research and public health initiatives are important. So you need to update treatment guidelines and syndromic management protocols. I know that we don't really, in dermatovenereology, we don't really emphasize syndromic management protocols, but it's there, and it's there to stay. People use them, especially in resource poor communities. They still use them, so we need to remain aware of them and be abreast of what's really going on there. Then promote antimicrobial stewardship for STIs. Provision of education and resources, it's key. Promote STI research and new drug and vaccine development, then antimicrobials and therapeutic regimens. And so those are all the treatment or STI treatment optimizations that are important. And the newer antimicrobials for some selected organisms, Neisseria gonorrhea, Mycoplasma genitalium, or T. vaginalis, that are in the pipeline. They are in different phases of clinical study. And it's we need to be, they're not yet available. And even the one that is available, that's a pristinamycin, available in Europe and Australia, is special access availability. And then citalfloxacin is available only in Japan, but we just need to know that they are there. Secnidazole has actually been there for a while, because I think there's an older study. Now, in summary, while traditional lab diagnosis are still options for diagnostic methods, really are still options for diagnosis of most STDs, especially in resource poor settings, increasingly nucleic acid amplification tests are finding high utility because of their higher sensitivity, specificity, use of different specimen types, and shorter result turnaround time. However, their costs are quite high, almost prohibitive for us. But if you want to do a study, I think that's probably the way to go, because that way you will have a higher yield of positive results, because of the high sensitivity and specificity. Drug resistance is an issue in some STDs, especially gonorrhea. Development of vaccines for different STDs are in the pipeline and may help reduce disease burden. And prevention and public health interventions are still key. We know that we have a lot of things happening. Globalization has taken place. We have MSMs in Nigeria. We have bisexuals. We have transgender males and females. We need to know that they are there. We can't afford to play the ostrich. We need to know they are there. And some of them are actually still having intermingling with having, doing a lot of sexual mixing. We need to know that they're there. We need to have a lot of public health educations in our environment. Since we don't have the resources for some of this, at least we can try as much as possible to help prevent some of these things as much as we can. Thank you so much for your attention, and then I'll wait for the questions.
Thank you very much, Madam, for the wonderful presentation. I'll just try and maybe do a little summary. She introduced STDs and STIs for us, told us the scope of the STI epidemics and the drivers of late presentation in STD, asymptomatic disease, especially in female. She talked about stigma, preventing people from coming early to the clinics. socioeconomic drivers like poverty with its attendance factors, and also lack of access to health care. She talked about the increasing prevalence of STI in MSMs and also in socially disadvantaged peoples. And she also talked about the gap in the development of STI investigation tools or treatment tools. She raised question about antimicrobial resistance, which has been significant. And in fact, among the regimens she gave for the treatment of gonorrhea as late as 2006, 2017, even the combination treatments like ceftriaxone and azithromycin have had organisms reported to be resistant to those combinations. Then she talked about chemsex and gonorrhea. Chemsex are drugs used to extend or intensify sexual sessions. And of course, the risks are further increased when you combine them with some of these drugs you use for erectile dysfunction. So she talked to us about advances in the diagnostics of STI, especially NAT, which is used to detect antigens using PCR and other techniques in especially chlamydia and gonorrhea infections. She talked to us about screening for STI in special groups, especially chlamydia in young and pregnant women. And then she told us about the screening test, mainly NAT. Sometimes you need to do culture, other times antigen testing. She talked about the samples and sample collection techniques and the test done on those samples, especially for gonorrhea and chlamydia. Then she gave us the treatment options. Then for chlamydia in the investigations, she talked about limitation of culture because of the duration and difficulty of the culture process. She taught us about non-culture diagnostic techniques. And then she brought us a new organism, relatively new organism, Mycoplasma genitalium, which causes about 15 to 20% of non-gonococcal urethritis, and told us about the difficulty in making diagnosis and suggested that we should have high index of suspicion, especially in people with persistent or recurrent infections, and gave us a treatment option of moxifloxacin. Then she talked about syphilis, and the highlights there is the paradigm shift in the syphilis screening tests. While before we did the non-treponemal before the specific treponemal test, now there is a shift to doing the treponemal specific test before repeating the non-treponemal tests. And of course, there is good news there that syphilis, the organism, is still faithful to penicillin, and penicillin is still the drug of choice. She talked about antibody tests for people who have neurosyphilis from CSF. Then she talked about herpes simplex virus and talks about the prevalence of up to maybe about 500 million infections annually, and seems to be increasing. HSV1 is becoming increasingly a cause of genital herpes. So she made mention of molecular assays for rapid diagnostics. And then she told us the drugs of treatment and newer drugs like amenamivir and the use of microbicides such as tenofovir gel to prevent infections, and also mentioned the use of essential oils in the treatment of herpes infections. HPV, she talked about the disease, and then of course the screening test for particular populations, including cytology, NAT screening, that several forms of this screening test are now available. For trichomonas, she mentioned point of care tests that are usually antigen based and sometimes specifically NAT. and he's also introduced the intravaginal siRNAs, which are used to prevent or slow down STI infections. And then she gave us a list of new antimicrobials or new existing antimicrobials that are now being used in the treatment of STIs. So all in all, I think she did a good job and did what we wanted her to do. So with your permission, we'll go into the questions. I hope I'm being heard.
Yes, I can hear you.
Yes, sir, you are being heard, sir.
So there is one question. Somebody is asking whether there is still gonorrhea. He hasn't seen gonorrhea in the 4 years. He has only seen one case of gonorrhea in a private setting. And then for genital herpes, sorry, the thing keeps shifting. That for genital herpes and HPV, the prevalence has increased. He thinks we need to develop more capacity in that direction. So do you still have gonorrhea? Not you, do we still see gonorrhea?
I think the question is for me, right?
Yes, ma'am.
Yes, I think it's something
So
that
maybe you can just take the questions from your end under the chat.
It's okay. There was something I wanted to pull up concerning,
Yes.
actually concerning that gonorrhea.
Yes,
The thing is, okay, no, it's the study. So if you look at this study that I quoted, it says that over 95% of STI cases were symptomatic. This was a study that was carried out in MSNs and transgender women in Nigeria. And some of them were also, I think, bisexual. He said over 95% in this study, and this was in 2016. So if they're asymptomatic, they're not coming to you. That's the truth. So they were able to get this study, these figures, because they used this newer nucleic acid amplification tests. We're not seeing them. It doesn't mean that they're not there. I know I've seen. In fact, one time in clinic, I saw somebody whose son came with a classical gonorrhea, classical. He came and there was a history of sexual exposure. He had gone for a program. He had unprotected sexual intercourse. He had the painful dysuria. It was classical. It was amazing. Okay. And then after some time, I think, I won't say, at a point I was wondering if it was familial, because a couple of years later, the younger brother came with the same thing, and classical as well. Are we seeing gonorrhea? I know I've seen a few cases. If we're not seeing, I don't think it's because it's not there. I think it's because we don't have the right tools to test for them. Number two, many of these patients, we know about drug abuse. I was talking with someone the other day. He's a Nigerian. He said that someone had diarrhea and was looking for Flagyl. And he said, well, he doesn't have, but that's the other day he had diarrhea. And he asked his friend, who is a doctor, to write a prescription for him here in the US. And he was able to buy just one capsule of ampicillin. And he said one capsule of ampicillin does it for him. And that's it. So a lot of us, some use one capsule of ampicillin for one thing or the other. Some people after sexual intercourse use ampicillin, use any of these things. They use maybe one capsule as a post-coital prophylaxis. So we have a lot of resistance. We have a lot of treatment over the counter. So some of them are not presenting with the classical symptoms. So I am very, very sure that we have gonorrhea. But I think this should open up room for further studies. If we can have collaborations with people that are able to fund this research, I believe it's something we should look into, probably as an association or as individuals who are interested in STIs. I think it's something we should look into.
And sorry, additional comment. let's remember that we all practice in tertiary health centers.
Yeah.
Most of these people with symptoms of STI will usually go to the chemist or the local general hospital. So except if it's complicated or recurrent, we are not likely to see them in the tertiary center. Like this study you mentioned, the one done by Walter Reed and Nigeria Ministry of Defense.
Mm-hmm.
Actually, most of the people you find there are university students. Because in the two centers in Abuja and Lagos, I went to demonstrate to them how to do cryotherapy for wards. And most of the patients there were university students. So it's common and it's available and they have most of those things. And I think the defense lab is the only one that does NAT testing in Nigeria for now. I don't know of any other.
I know there's this research center. I don't know if it's in, they do a lot of, high capacity tests in Ede, Redeemers University, Ede. I know they do a lot of PCR testing. So they probably would have the capacity to do that.
Okay.
Yes.
So next on the chat.
Yeah, please, can you, because I don't know what I did, but I think my
chat. Somebody is asking, role of formats, public toilet, and washing basins. Sorry, somebody's question. Mm-hmm. Role of formats, public toilets, washing basins in spreading STIs.
I don't.
In fact, let me help you answer that one.
Okay.
We had an old professor in Zaria, Professor Egler. I'm sure the person that asked the question knows him. He said, yes, transmission of gonorrhea and other STIs is possible in the toilet, but not without intercourse.
Exactly.
So it's not impossible, but most of the time people look for what to blame for their problems.
That's true.
You can't get gonorrhea from a public toilet, no, from a washing basin. Yes, ma'am.
Yeah, but yes, usually you don't. Of course, except you're talking about something like scabies as an STI, then yes, you could think about formites and all that, But even at that, it's not, people, once someone has something, because of the stigma attached, everyone wants to link it to something. So you just want to, say, I went to the toilet, I used the public toilet, and after that I started having discharge. So it's not, you never say never anyway, but I haven't seen any study supporting that. But you would say, of course, we know that you still have, even amongst them, lesbians, you can have sexually transmitted disease. I don't know, probably due to use of shared, those they are shared things, maybe vibrators and all. You can have STIs amongst them, especially STIs like genital warts. They have, studies have shown that they have that. Genital warts, and I've seen one case of a molluscum contagiosum in someone who was practicing lesbian sexual activity. So you can have those ones, but you never say never. So that's the way I'll put it. And I think I had seen earlier, I think one of the first questions was on genital warts in women, pap smear in women who present with genital warts. What do you counsel them? Definitely, once someone has had genital warts, is a high indication, is a high risk thing. Some people that are actually enlightened will go ahead and do the HPV typing. I had somebody, an MSM, come to me. He came to me, said he was an MSM, and he had genital warts. He went and did his typing. I think he did it in Synlab or somewhere. And then he found out it was HPV, I think 16 or 18. So people go ahead and do the typing. But even if you can't do the typing, definitely it's an indication for screening. Usually, once someone presents with genital warts, I usually encourage person to go for pap smear, and then they need to continue. For them, I don't think the yearly option is even an option. If they're not able to do the typing, definitely they must do it yearly. Some people actually advocate for a shorter duration, maybe about 6 months after treatment, they should do the pap smear again and then continue follow-up. So yes, it's important. And then I think there was, I saw, so I don't know if
There's
that's
a
Can
question
I
of
help you out?
okay.
There's a question here on what do you advise on marrying the diagnosis treatment of MSM with the laws against MSM in Nigeria? Should one be in that net? How best can one navigate successfully?
Even if there are laws, we're doctors. So when someone comes to you and says that he's MSM, you're not going to go, are you going to go and call the police? I don't know. You're not going to call the law enforcement people, okay? We know that definitely, whether we accept it or not, everyone knows that the highest incidences of STIs are among MSMs. So usually, for me, I wouldn't say I preach at them. Some of them will actually tell you they want to stop because it's really high risk. So, but you do your own job as a doctor, and then, counsel the person as best as you can, but you don't, the person has come to you confidentially. So it's not something you put out there, or you call the security operatives. You treat your patients individually as they come. I don't know if that's the question.
Yeah, I think so.
Yeah, they come to you, you treat them. You can't.
There's this you're obligated as a doctor not to report, I think.
Okay. Yes.
You're not supposed to go and say this person, I just treated an MSM. You're not entitled to do that.
No.
Sorry, there is a difference between treating a patient with a medical condition and facilitating his sexual orientation.
Exactly.
You came to with a medical condition, you treated it. His sexual orientation is his own issue.
That's it.
But where you are now organizing special clinics and other things for them, that is where there may be problem.
Professor Gubi, okay, sir. Professor Gubi wants to know where we stand with the syndromic approach to treatment, which is still done by other healthcare workers.
It's still, yes, Prof, thank you so much for the question. The truth is, because we practice in tertiary institutions, if we can carry out those tests, those the testing, we still go ahead and do the testing. But at the primary care facilities, that's still what is recommended. And I don't think we can really expunge it. We can't do anything about it. Syndromic approach is still ongoing, even here in the US. It's still ongoing, especially in ethnic minority population groups. They still do a lot of syndromic management. So it's not something we can kick against. It's not something we can stop. But what we do is that when these patients come to us and we have facilities, even for epidemiological purposes, if we can screen them and they were able to do that, I think it's still the best thing to do, to screen them, especially for us to have data on epidemiology. What is it that our patients are actually presenting with? But yes, it's still ongoing, especially at the primary care level.
And then the follow-up question on that, even at the teaching hospital level, how many of our hospitals are equipped to give you diagnosis, etiological diagnosis for most of the syndromes?
It's a problem. It's
and even the turnover.
It's a problem.
Sometimes I wanted to know why the screening for gonorrhea is recommended for those that are less than 25 years.
This is CDC recommendation, and this is for US. And I think it's because they believe, that's the highly active age group is that age group you're targeting them. That, people that are probably above that age are already sexually mature. They know what they need to do. So you want to target as many as you can. I think that's really the rationale for it. And that's a recommendation for the US.
Okay.
Yeah.
Sorry, what are the challenges in the use of HPV vaccines for the prevention of HPV infection in girls in Nigeria?
It's a big, a lot of people believe that. One of the things is a traditional thing. Maybe if I give my children the vaccine, they will become sexually promiscuous. It's there. It's not just in Nigeria, it's actually global. Then the other thing is some people believe that they may actually acquire the vaccine, the virus from the vaccination. So that they don't want to do that. Then the other thing is also the cost, availability and cost. Some people can't afford it. So those are some of the challenges that we have. I don't know. We are dermatologists. Some of us have daughters. If you take a census, how many of us have actually gotten our daughters vaccinated? So
what are the indications for surgical management of genital warts?
for me, when once someone comes with huge genital warts, especially obstructing the introitus or really disfiguring, I usually send them to the plastic surgeons or the gynecologists. When they remove them, we start treatment, because there's some that you just cannot treat topically, no matter what it is you're using. So you debulk, is a kind of debulking, and then you use your chemotherapeutic agents. That's what I've always done. I don't know if any other person has something else to share.
Then somebody is talking about STI in children from sexual abuse, especially anal. What's your opinion on this?
What, my opinion, in what sense? Is it whether investigation or in treatment or in prosecuting the people that caused it, or what? I'd like to understand further. Definitely, it's happening.
He mentioned sexual abuse, so maybe how to prevent sexual abuse.
Well, I think it starts from our grassroots. It starts from us in our various places I don't know whether you're a Christian, a Muslim, even in your places of worship, in your neighborhood, as much as possible, amongst your friends. Put the word out there that a lot of the sexual abuse that goes on starts from the home. It could be people that come to help, house helps and all that. It happens all the time. So let's put out the word. Let people, in church, what I used to do, when I see young children go to the bathroom, many times I'll go to the parents, the mother, get up and go with your child to the bathroom. Because a lot of things happen there, In fact, the other day, my sister, I was talking with my sister, and she said somebody was telling her, about this young boy who said he was introduced to anal, sex in either, I don't know where he was, but, a small boy of his age, at the age of 8 years, he developed, he started having anal sex due to sexual abuse. And then, they brought him to the clinic. The parents work in one of these high profile places, these oil companies that have their clinics. So it was the nurse that was actually telling my sister. And she was saying that apparently they didn't know when it started. And then that same boy was eventually put in a boarding school. The mother said she was sleeping, he was sleeping, and one day she walked into his room, she perceived the smell of feces. And she walked in there and found out he was sleeping at the age of 10 years, and he had, passed feces. So he had developed rectal incontinence, he had developed incontinence of feces. And at that, as we speak, he was on admission in the hospital. And he now started talking about his experience when he got into the boarding school. He actually went PLC, having several partners at a time. So it's happening. But if you don't know it's happening, you probably won't know how to educate people. You start from when they are young, begin to educate these young people. Tell them it's happening. They are sexual predators. And sometimes the predators are children of the same age. Because if someone has been preyed on, the person ends up becoming a predator. So start from there, talking to them about it. People that have people living with them, you have to be aware that these things happen. These are no longer the days. I remember when we were growing up, they say if you're a female, don't have male house helps. But even female house helps who sexually abuse even their female children care of. So be aware that it's there. And then when these things, when you notice them, treat them as much as you can. I remember a pediatrician telling me about one young girl that she treated. The girl eventually became, she eventually went into medical school. She said that when she was young, I think it was either the house help was bringing in her boyfriends and they were sexually abusing the girl, that she treated her a couple of times for gonorrhea, and that when she sees her now, she's now married, but at least the last time I spoke with her, she hasn't had any child, that she developed a lot of complications. So it's there. We need to put out the word in our little corners. Let people know it's happening. You know, when you discuss with your friends, let them know it's happening. And then when it happens, sometimes those little children will actually confide in you. You have to find a way. Sometimes you really have to find a way of creating a balance between keeping their secrets and then informing the parents. I don't know if anyone has any experience to share on that. Yeah, but it's really something very delicate.
Aisha, you were saying something. Can you unmute Aisha? Secretary. Hello, Aisha, are you on?
Yes, can you hear me?
Yeah, you were talking about happenings during the pandemic.
Okay, well, so from my experience, I belong to two women's group, and they both deal with gender-based violence and all of that. So it was mainly targeted at women, married women or single women, adults. But, before that, there had been one or two issues of things like this happening. But throughout the epidemic, the thrust had to change, because what you found was there was so much sexual abuse. So, and when you hear the stories, you find that in the society, it's condoned. There is such a family and cultural taboo. People don't talk about it. And just, have that culture of silence. I recently saw something which made me Google, and I checked a lady. I've forgotten her name. It's the guy who did the music videos for Fugees. I saw something and I Googled it. The lady wrote a book, and the man, right, had sex with his two children in the house. And this lady had five children from him. And he made them believe, so sometimes when you read the stories, you just see that, first of all, apart from, yes, we should protect the younger ones, children, let them learn. But it's the adults in our society that are perpetrating these heinous crimes. And we are condoning it and hiding it. And, you don't know what to do, So there's really a lot. I mean, that group that I'm on, I'm so tired every single week, videos and news about these kind of things, because that's what they do. It's really terrible. It is. I don't know. I really don't know what we're going to do. I just wanted to contribute that.
It's really.
Well, Shakira is suggesting that we need to talk about sexuality more, and then children should be given age-appropriate sexual education.
Yes, it's definitely, it's not optional. I know that when I started having children, I started from when once you're old enough to talk, I start sexual education. I had to start because I knew that it was happening. So parents need to talk. It's like what Aisha said. Where I used to worship back home in Nigeria, when I got to the church, I had to tell them that we can't continue keeping silent. In fact, you're talking about culture of silence when it comes to sexual abuse. We're talking about culture of silence when it comes to even discussing sexual matters. You find out that there's some mothers that can't discuss sex with their children. It's a taboo. They don't. So the children hear about it from outside. They discuss outside. So we need to talk.
Hello?
Hello.
Hello. Yeah.
President.
Okay. Sorry about that.
Yeah.
Okay. No problem. So we just need to keep talking. It's something that we can't ever get tired of. And yes, it's happening in families. It's happening.
Sorry, please, can I just ask here that
okay.
What is expected of us as medical doctors? It's just like I'm trying to link up with Dr. Sebastian's question, because if you see a child, an adolescent that is not an adult with sexually transmitted disease, is it also our responsibility to alert the authorities? It's not just is it just treat and go, or do we still at least go the extra mile and alert the authorities that such and such is happening to such a child.
Yeah, in most institutions, you have what do you call it? A social
social welfare.
Yes, social welfare. It's something that must be brought to their attention. They are the people that usually handle it. But sometimes actually, when you bring it up, the parents don't want to talk about it. What do you do? You know, what do you do? So sometimes when it happens, you get the social welfare involved. But if the parents don't want to talk about it, you can't force them to go to prosecute.
But can't we go above them and report?
No, I don't think we. I don't think
that's,
we have that
that's
right.
what Madam Ahamefle said. You report to social welfare. Social welfare will investigate and take it up.
Yes.
Exactly.
And she put up something about sex education for kids. So if you check the charts.
Yeah, definitely. You have to tell them what is age appropriate. The question is who determines what is age appropriate. We should know, at least even as mothers, we should know what's age appropriate. You don't go telling them about the whole sexual union and all. At least you tell them about their sexual organs, tell them about people not, that those places are special. They should call it by name. They shouldn't call it, they should call it by name, talk about it. But that those areas shouldn't be touched by anyone. You know, they shouldn't, you tell them that there are places that people shouldn't touch. You as their mother, if maybe you're the one. Again, some mothers are really careless, I would say. So you get people, sometimes you get strangers bathing your children, and sometimes that's when it starts. I don't know. I don't know. We could spend the whole day talking about this. It's happening everywhere. It's happening everywhere. Okay, Aisha. Aisha said you inform the parents and contact the Lagos State Ministry in charge.
Yeah.
And what if the parents don't want to prosecute? What do you do?
No. By the time you inform
social welfare
out of the picture about prosecution.
Yeah.
And even now.
No, ours is not to prosecute, though. It's just to inform the state government. You know, they know what they do. That ministry in Lagos State is very active. We just inform them, and then they take it from there. You know, because many times it's not really about prosecuting. It's also sometimes it's internal. Relatives staying in the house, one uncle, one brother, one this. You know, but they do know what to do. I must give it to them in Lagos State. They are really on top of it. But it is just rampant everywhere.
It is. It is.
All right. Thank you very much, Madam Chinwe, and thank you all participants for coming in. Madam Secretary, do you have any announcements?
Yes, I do, sir. Tomorrow is the 1-year anniversary for the death of one of us, Professor Joseph. Yes, so please let's put her and the family, let's put them in prayer, the family in prayer. Also, we've been invited to attend a memorial service in her honor. Start with communion service at Vine Memorial Church at 7:30, and then reception at 10:30. There's also, you can also attend by YouTube or Zoom. So please, let's remember her tomorrow. Let's remember our colleague, Dr. Cole, tomorrow, and her entire family. Continue to pray that her soul rest in perfect peace.
Amen.
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 Also, for those that are yet to register for our conference, please do try to register. We want everyone involved. Our conference comes up in 2 months' time. Please, let's save the dates, 15th to 17th of June. We want everyone involved. It promises to be everything that we hope it to be. Thank you, Mr.
Are we
President.
paying late registration fees for those of us that haven't registered?
No, there's no late registration fee. Just pay, yes, and attend. Yes.
Okay.
Are you still accepting additional registration for physical attendance?
No, we're making it open. We're collecting the same amount for everyone. But
No. What I mean, those who want to attend physical attendance there at the meeting. Are you still
There's no
taking it?
extra cost. There's no extra
No, I'm not
cost.
talking of the cost. I'm talking of whether you are still taking additional people for physical attendance.
Yes, I think we still can. We are yet to reach the target of 50.
Limit, okay.
Yes.
So please, let's make the announcement that it's still open people who want to attend physically. And I think for the hall and the dignitaries we are inviting, we'll need more people to come physically.
Yes. And if you need accommodation, please reach out to us too.
Free?
Sir?
All right, we'll reach out to you. All right, thank you everybody for making it worthwhile. I hope we'll be available for our next session to last weekend of May. Then I think it will be something on lupus. It will be presented by rheumatologist from Chicago. So let's make it a date. Thank you very much, everybody.
Thank you so much. Thank you.
And special thanks from Obodo Ibo.
Thank you. Thank you so much.
Bye.
Ma? Oh, dear ma. Oh, dear ma. I will call you.
No problems. Okay,
I'll call you, ma.
Some of us understand the language.
I know.
As though you have your association should have been such that you can understand everything now.